Geriatric Service here at Jersey Shore University Medical Center. Welcome to another episode of Geri Short Talk. And in this talk, we are going to talk about how to reduce the risk of delirium in our patient population. So, like every disease, prevention of delirium is much more cost effective than treating delirium. I'm sure on the floor you've seen a lot of patients who were delirious, and you've witnessed how treatment of those patients has been very, very challenging. On the other hand, there are simple yet effective interventions that can be implemented in order to reduce the risk of delirium and hopefully preventing delirium in good portion of our patient population. So we are going to talk about a few of those uh, interventions today. So the first one that I want to talk about is hypoxia. Um, as you know, a lot of our patients are admitted with heart failure or COPD exacerbation, or even if they're admitted for other reasons, they have heart failure and or COPD as part of their comorbidities. And as a result, they may need oxygenation during their hospital stay. So the first step in management of hypoxia is simply avoiding hypoxia. So many patients wear oxygen during their hospital stay, and that oxygen may fall off, and they may go through a period of hypoxia, which can then lead to delirium. Um, if you encounter a patient who's restless, who potentially has had the history of COPD or heart failure, or has been admitted with those sort of conditions, make sure that you check for oxygenation, because if you only give them antipsychotic medications, that will worsen hypoxia, which in return will also worsen delirium. Obviously, monitoring for hypoxia is very important. There might be times that the patient might be hypoxic for 10, 15 minutes before we even get to the patient. So that is very important to consider. Obviously, in a patient with acute onset of hypoxia or new development of hypoxia, workup might be needed. Obviously, our care providers will be able to assist. They can rule out PE, they can rule out pneumonia, and other reasons behind the new onset of hypoxia. And treatment of hypoxia by providing adequate oxygenation can lead to um, reduction in the risk of delirium, or even if the delirium happens, the severity of that would be much lower. The second point that I have witnessed on the floor is poor PO intake. A lot of our patients are old and frail, and they might be at risk for poor PO intake. So it's very important to monitor them for their PO intake. If need be, calorie count, and our great dietitian would be able to help with that. Sometimes you're concerned about difficulty with swallowing, the risk of aspiration. So our speech and swallow evaluators would be able to assist us with that notion. One of the things that is very important in older patients is whether they have dentures or not, and whether they have dentures with them in the hospital. Obviously, for patients who wear dentures at home but they don't have it here, swallowing and chewing of the food can become difficult. So we need to pay attention to that. The other point of intervention is that if the caregivers are at bedside, family members, and if there is no dietary restriction, or if there is dietary restriction, within the limitation of that dietary restriction, ask caregivers to assist with feeding. They are there to help their loved ones. They want to play an active role in that care, and empowering caregivers to actively participate in the care will likely lead to better, higher level of satisfaction with the hospital care as well. Obviously, if there's no family members at bedside, if you have time, please assist with eating of these older, frail patients. Some of them may even be unable to reach to the food tray that is at bedside, and some of them may even know that the food tray is at their bedside. So assisting them with feeding would be very helpful. The other point is avoiding daytime sleepiness. This is very important. If a patient sleeps 8 or 10 hours during daytime, they probably miss 1 or 2 meals a day, and as a result, they cannot make up for the missing calorie intake, even if they have a very large, dinner or so. So avoiding daytime sleepiness is extremely important for reducing the risk of delirium. One of the global recommendation is being out of bed and participating in various exercises. That will help with the PO intake. And then the last one, obviously, if you go through all the interventions and still the patient has poor PO intake, um, and the family is asking for appetite stimulant, you may consider that. Although my suggestion to you is that at that point, consult with either gastroenterologist or geriatrician or geriatric service team, because when family members ask for appetite stimulant, we just want to make sure that we understand their point of concern, and we make sure that the rest of the interventions have already been followed and they were successful. And we need to talk to them about the risk and benefit of these appetite stimulants in an older, frail patient with poor PO intake. Uh, Nonetheless, in some patients, it might be helpful to use appetite stimulant. The next issue, which is fairly common in many institutions, is poor urinary output. So the first, which can then lead to the delirium. So the first step in that, for solving that problem, is just to measure the problem. So if we do not measure the urinary output, we don't know whether the patient has had poor urinary output or not. So for many of these older, frail patients, measuring urinary output and documenting it is extremely important. The reason is if they have had poor urinary output, either they have had urinary retention, which you can detect that with bladder scan, and then a straight cat would help them, and then that will reduce the risk of delirium, because the simple urinary retention can lead to delirium. Or they have been dehydrated, either because they have had poor water intake, or they have been MPO for a long period of time, for various procedures and so on. And obviously, the treatment of these sort of situations, urinary retention versus dehydration, are completely different. One thing about poor urinary output that is very important is check medication list and look for anticholinergic medications. Some of these medications are prescribed in the outpatient side because the patient was complaining of urinary incontinency. Some of these patients have gait and balance impairment, and a little bit of urinary incontinency pushes them to rush to the bathroom, and they really don't want to experience that. So at times, primary care providers prescribe anticholinergic medication to overcome that challenge. These medications in the hospital can then lead to urinary retention, and on its own can lead to delirium. So definitely in the hospital, there's not a lot of concern about urinary incontinence, and some of those medications can be discontinued in a very safe manner. And then you can let the primary care provider know, so they can decide whether they want to restart that medication or not. And then the next one, and the last one that we're going to talk about in this episode of Jury Talk, is global exercise. And the reason that I mentioned global exercise is because it's not just about the physical activities, respiratory function, is the cognitive function, and all of those things basically is global exercise for these patients. So the first one is, again, once as we discussed before, is patient being out of bed as soon as possible, sitting in the chair, walking a little bit helps reduce the risk of delirium significantly. Our physical therapists and our occupational therapists are available to help us in case we have any concern about the safety of patient being out of bed. But for the most part, if the patient has been admitted because of, let's say, heart failure, and at home they are completely independent. They walk uh, without any issue, or even if with issue, they manage their daily activities. It does not make a lot of sense that we keep these patients in bed because they have been admitted for heart failure. They can sit at least in the chair, if not walk, in the hallway. The next one is incentive spirometer, which is extremely important, not only for respiratory function, but also in order for the patient to operate incentive spirometer, they have to follow 3, 4 different steps in order to do that properly. That 3, 4 steps makes them more focused on the task that they have, and that will allow their attention to be increased and as a result, reduce the risk of delirium. Frequent reorientation to time, place, and person is extremely important, and this should be done by almost everybody, if not everybody. And it doesn't require clinical staff, even non-clinical staff that can participate in that exercise. You simply ask the patient about what time of the day is it, where do they think they are, what's their name, if somebody's at bedside, who that person is, etc., etc. And if they answer the wrong question, they answer in a wrong manner, give them the correct answer. If you have time, wait for 10 seconds, 20 seconds, and ask them again the same question to see if they register the correct answer. Do not feel disappointed if if the patient is unable to register the correct answer. Together, if we do 10, 20 seconds of work with the patient, um, that patient may have a reduced risk of ending up with delirium. The other thing that you can do is when you ask them about what time of the day is it, um, some may say, "Oh, I don't know," and you can ask them or tell them that there might be something on the wall that can help you figure that out, and see if they understand that something on the wall may mean clock. So if they are looking for a clock, that's a good sign. Unfortunately, some have vision impairment, so even if they see the clock on the wall, they may not actually read the time, but the notion that they understood that there's something on the wall and that could be clock, and he or she is asking me about the time of the day, so I should look for a clock, is a very good sign, and we should keep doing that with these patients. Obviously, last but not least, ask family members to engage with the patient. Many times family members are at bedside, but they really don't know what they should do with the patient. They are fearful, they're concerned, they're frustrated. For many of them, the acute illness of a loved one is a significant tragedy. Um, but we need to guide them and empower them to engage with the patient, show that patient, familiar photos, familiar faces, and ask the patient, whether they understand who that person is or who that photo belongs to, etc., etc. That will keep the brain functioning. So utilize, if family members are at bedside, consider them as the partners in the care. Talk to them about engaging with the patient, and and that way, together, from the patient side, family side, as well as the clinical and non-clinical side, we would be able to reduce the risk of delirium. These are just simple interventions that we can do. It's not comprehensive. Hopefully, in the next episode, I'm going to talk somewhat more on um, the other interventions that can be done to reduce the risk of delirium. And I think the delirium is one of those things that it takes a village to reduce that risk. But once that risk is reduced and we see the uh, improvement in some of the indicators that we are looking for, it it's it's because of our collective effort. It's not just because one person did a great job or another person did a great job. It's a collective effort, and it's a collective, continuous effort of all of us. Um, I appreciate everything that you do for our patients. Geriatric service is always available to assist you in any question or concern that you may have. And I'm pretty sure that together we will improve outcomes of our older patients. Thank you.